Hello, my name is Elena Smith, and I am a quality consultant with the Lake Superior Quality Innovation Network. Today I'm going to be discussing the Quality Payment Program and what's new for 2019. First, I'm just going to start off with a quick disclaimer. The content provided in this presentation is based on the latest information made available by the Centers for Medicare and Medicaid Services and is subject to change. CMS policies change, so we encourage you to review specific statutes and regulations that may apply to you for interpretation and updates. The objectives I'm going to cover today include highlighting changes to the 2019 Merit-Based Incentive Payment System, or MIPS, and I'm going to be discussing 2019 alternative payment models. So just some quick background. So what is the Quality Payment Program? It was established by the Medicare Access and CHIP Reauthorization Act of 2015, which ended the Sustainable Growth Rate formula. And there are two participation tracks for eligible clinicians, MIPS and APMs. Each year, a new final rule is released that highlights some changes to the Quality Payment Program, and I'm just going to discuss a few of those coming up next. So the goals for Quality Payment Program Year 3, which is 2019, include the program's measures and activities are meaningful, improving patient outcomes and reducing burden, and clinicians have a clear way to participate in advanced APMs. So one of the big changes for 2019 MIPS is that there are new eligible clinician types. So in previous years, physicians, physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists were all MIPS eligible clinician types. This year, they added several new clinician types, and those include physical therapists, occupational therapists, speech-language pathologists, audiologists, clinical psychologists, and registered dietitians or nutritional professionals. Now, in order to be eligible for MIPS, you have to be one of those eligible clinician types, but you also have to exceed some low volume thresholds. So clinicians and groups are excluded from MIPS in 2019 if they bill $90,000 or less in Medicare Part B allowed charges for covered professional services payable under the physician fee schedule, or furnish covered professional services to 200 or fewer Medicare Part B enrolled beneficiaries, or provide 200 or fewer covered professional services to Medicare Part B enrolled beneficiaries. So luckily, this isn't something that you have to keep track of. CMS is doing all of that behind the scenes, and they actually have a great resource on the qpp.cms.gov website, the Participation Lookup tool, where you can enter in a clinician's NPI, National Provider Identification Number, and you'll be able to see if they exceeded all three of these low volume thresholds and are eligible for MIPS. In addition to that, there are two MIPS determination periods. So as I just mentioned, there's that participation lookup tool, and currently in July, that participation lookup tool is looking at October 1st, 2017 to September 30th, 2018. The second determination period will look at October 1st, 2018 to September 30th, 2019. And in the recent news, I've seen that CMS says that that data will be available sometime in December. So you must be eligible during both determination periods in order to be eligible for 2019 MIPS as a whole, unless you start a new taxpayer identification number sometime within there. So what does that look like? So this first clinician is eligible currently. They go onto that lookup tool and they see that they're eligible, and then they go back in December to double check and they see that they're eligible again, and that clinician is eligible for 2019 MIPS. The second clinician started a new TIN somewhere within that first determination period and then goes back in December and sees that they are eligible. They are overall eligible for 2019 as well. Numbers 3, 4, and 5, they at some point are not eligible, either right now or in the second determination period or both, and overall that means that they're not eligible for 2019 MIPS. One thing to keep in mind is that the eligibility is determined for each TIN/National Provider Identification combination. A MIPS eligible clinician associated with multiple practices may be required to participate in MIPS at one practice and ineligible to participate as an individual at others. So just keep that in mind, and that participation lookup tool does really break it down nicely and makes it very clear to see which practice or which TIN you are eligible for MIPS within. A new option for 2019 is the opt-in option. So if a clinician exceeds 1 or 2, but not all 3 of those low volume threshold criteria, they have the option to opt in. And if you are an opt-in eligible clinician type, it will look somewhat very similar to what's shown on the bottom of the screen there, where it shows that you're not MIPS eligible as an individual or group, but it says that you're opt-in eligible as an individual or group. So one thing to keep in mind, once a clinician opts in to 2019 MIPS, they are not able to opt out, and those who opt in will receive a MIPS score and corresponding payment adjustment. One thing I do want to note about this opt-in option is that CMS doesn't have a policy or a procedure in place quite yet to allow clinicians to say that they would like to opt in, but it is something that will come down the pipeline here soon, and I do suggest signing up for the CMS Quality Payment Program listserv. If you go onto qpp.cms.gov and scroll down to the bottom of the page, there is a section where you can enter an email address and sign up for that, and that's how you'll be able to keep up to date with all of the new Quality Payment Program information. So the reporting options for 2019 really haven't changed from previous years. So you can report as an individual, as a group, or as a virtual group. And clinicians participating as a group are assessed as a group across all 4 MIPS performance categories. So some special statuses. So another thing you might notice if you enter an NPI on that participation status lookup tool is that towards the bottom it will say some special statuses if they're applicable. So the first one is hospital-based. So a hospital-based clinician sees 75% of their patients within specific place of service codes. And if it says that you are a hospital-based clinician, that means that your promoting interoperability category is related to your quality category. That's oftentimes because you promoting interoperability has to do with electronic health record technology. And if you are seeing so many patients within the hospital, you likely don't have access to that electronic health record technology information. Non-patient facing, again, they have their promoting interoperability category related to their quality category. And these non-patient facing clinicians are oftentimes clinicians like radiologists. Small practice, so small practice in the past, their special status allowed them to get 5 MIPS percentage points added onto their final score. This year that has changed. It's not weighted as heavily. This year it's 6 points added to the quality category numerator, and I'll kind of show you what that looks like a little later on. And then finally there is facility-based, which is brand new for 2019. It sounds very similar to hospital-based, and it is similar in that, again, it's that these clinicians see 75% or more of their patients within certain place of service codes. They vary slightly from hospital-based. And those clinicians that are facility-based have their quality and cost category score determined by that facility value-based purchasing score. So oftentimes what you will see is if you are a facility-based clinician, it will let you know what facility you are attributed to and which facility's value-based purchasing score you would get. One thing that CMS is suggesting, and again, this is the first year that facility-based exists, is that they suggest that if you are a facility-based clinician, you still report your own quality data, because it might be that your own quality data is higher than that of the score of your facility, or sometimes the facilities don't report for this value-based purchasing program, and then you wouldn't get a quality score. So they definitely do suggest that you still report your quality cost. Is something that's done behind the scenes and you wouldn't report for anyways, so they would have that information. But if you don't report for quality and something goes wrong with your facility value-based purchasing score, then you wouldn't get a quality score. So definitely just keep that in mind if you are a facility-based clinician. So MIPS scoring for 2019 changed slightly from 2018. That change exists because they took 5% from the quality category and moved it into cost. And we'll continue to see the cost category score rise over the next several years. So that's how we get this 45% quality, 25% promoting interoperability, 15% cost, and 15% improvement activities, which gives us 100%. So the performance threshold. So in 2018, year 2 of quality payment program, the performance threshold was set at 15 points. So oftentimes that was pretty easily attainable because we had this improvement activities category that we could select some of those from and get those 15 MIPS percentage points. In year 3, 2019, the performance threshold has doubled and is now set at 30 points, which means we can't just rely on improvement activities to get those 30 points. We will have to do some quality or some promoting interoperability or both in order to reach that 30-point threshold. The other thing to keep in mind is that this threshold will continue to rise. So each year, it's in our best interest to always try to get the maximum score we possibly can, so that we're never falling behind in future years where that performance threshold continues to rise. So the payment adjustment has also changed. So in year 2, or 2018, the payment adjustment for 2020 payment year ranged from -5% to +5%. And then for year 3 in 2019, the payment adjustment for the 2021 payment year ranges from -7% to +7%. So what that means is if a clinician does not report for MIPS, for example, and would therefore get a 0 out of 100, they would automatically get a -7% payment adjustment for the year 2019. And the reason that it's listing for 2019, 2021 for that payment adjustment is because those payments are always offset like that. So you collect all of your data in 2019, you report in early 2020, you get your final score and you're notified of what your payment adjustment will be sometime in July. And then the following January, so for 2019, that would be January 2021, is when that payment adjustment goes into effect. So now that I've gone over some of those general MIPS changes for 2019, I'm going to get into each individual category, starting with quality. So for quality, like I mentioned earlier, you can earn up to 45 MIPS percentage points. The performance period is the full year. So this is something that we always suggest you have to be very proactive about. I know people get really, really busy in the beginning of the year working on reporting for the previous year, but quality does start on January 1st and ends on December 31st. So we need to be tracking those quality measures throughout the entire year. And there are over 250 MIPS quality measures to choose from. One new aspect of the quality category for 2019 is that there are multiple collection types allowed. So if the same measure is submitted via multiple collection types, the one with the greatest number of measure achievement points will be selected for scoring. So this is a really nice aspect of the quality category for 2019. It really allows you to maximize your score. So if you're able to track your quality measures in several different ways, you can upload both of those collection types, and CMS will look at both of those. If they're the same exact measure, just submitted via 2 different collection types, they'll give you the higher score of the 2. So they'll do that for each measure that you select, and then they'll really help you maximize your score. So one big change for the quality category has to do with claims reporting. So in the past, anyone could do claims reporting. This year, only small practices can submit via claims. So if that's something you did in the past and you are not a small practice, you will have to find a different avenue for submitting your quality measures. So some of the requirements for the quality category, so 6 measures are technically required, including 1 outcome or 1 high priority measure. And I put that in quotations because you can use specialty measure sets, and sometimes those specialty measure sets don't have 6 measures within them. So if there are fewer than 6 measures available within a specialty measure set, clinicians must submit all of the measures that are within that measure set. So for example, radiation oncologists, I believe, only have 3 measures in their specialty measure set. So those clinicians can't pick and choose based on their scores in those quality measures. If they choose to do these specialty measure sets, they have to submit on all 3. Another new aspect of 2019 MIPS is that there is an eligibility measure applicability, or EMA, process. This only applies to claims in clinical quality measures, or CQMs, which is formerly registry reporting. They kind of switched up some names. And it's triggered if you don't submit enough measures or if you don't meet the requirements, so that outcome or high priority measure. If the process finds more measures, they will adjust your scoring. So this is kind of what they do to determine whether this EMA process is going to go into place, if they're going to have to adjust your score. So are there more clinically related quality measures to the 1 to 5 you submitted because you didn't submit 6? And then they ask, are any of the 6+ quality measures clinically related to an outcome or high priority measure? So like I said, you could submit 6, but if you don't meet those requirements of an outcome or high priority measure, this will still go into effect. So they will do a minimum threshold test for claims. It would look like, were there 20+ eligible instances that were not reported? And the minimum threshold test for CQMs, or formerly registry reporting, were there any clinically related measures submitted with a 0% reporting rate? So if the full measure set is submitted, like I mentioned, that EMA process won't apply. So if you choose to do those measure sets, just make sure that you are reporting on all of them. If there are less than 6 or just 6, you have to report on all of them. If there are more than 6, then you can pick and choose of it, but still report on 6. So you have to submit all measures that relate to your scope of practice and don't limit the submission to those that are clinically related. And how to find those quality measures, you go onto the Quality Payment Program website, which is qpp.cms.gov. You'll click MIPS up at the top right corner, and this dialog box will pop up in the green. And down towards the bottom of that, you'll see Explore Measures and Activities. And you could actually be able to look at all the different measures for each one of the categories: quality, improvement activities, promoting interoperability, and cost. And you can kind of go through them to learn more about them and see what kind of collection types they allow. You'll be able to scroll through the specialty measure sets to see if one fits with your practice. It's a really great resource if you haven't checked it out yet. There are bonus points that are still available within the quality category. So 2 bonus points for outcome/patient experience measures after the first required outcome measure is submitted. There are 2 points for other high priority measures. End-to-end certified electronic health record technology reporting still does provide bonus points, and end-to-end means that there's no manual manipulation of data. It's just sent straight to CMS. And then bonus points continue to be capped at 10%. There is an improvement percent score this year, and it is based on improvements in total category score from 2018 MIPS submission. So higher improvement results in more points. So they look at what you did last year and compare it to this year. So here is that small practice bonus that I mentioned earlier. The small practice bonus is no longer 5 MIPS percentage points. It is now 6 points added to your quality category numerator. So this is what that looks like. Quality performance equals your total number of points that you got, plus any bonus points. If you're a small practice, they'll add that small practice bonus over the total available points within the quality category. And then if you get that improvement percent score, they'll add that on. So clinicians in small practices must submit data on at least 1 quality measure to be eligible for the small practice bonus. So if you'd like to get those 6 bonus points, you do have to submit on at least 1 quality measure. Now I'm going to get into the cost category. I'm not going to focus too much on the cost category, and the reason why is that you don't have to physically report on anything. You don't go into the Quality Payment Program website and have to input any information. CMS is tracking this all behind the scenes. If you reported for 2018, you're actually able to go into the Quality Payment Program website, check out your score, and look more into the cost category to see how you did. So within the cost category for 2019, you can earn up to 15 MIPS percentage points. And like I mentioned earlier, this will increase to 30% by 2021. There is no data submission required, and the score is calculated from administrative claims if the case minimum of attributed patients is met. There are 2 measure scores that were used in previous years, and those include Medicare spending per beneficiary, which assesses total Part A and Part B costs incurred by a beneficiary, and episode index hospitalization is used, where an episode equals 3 days prior to the hospitalization, period of hospitalization, and 30 days after hospitalization. Expected costs are based on clinical condition or procedure that triggered the episode and other factors. The other is total per capita cost measures, which assesses total Medicare Parts A and B costs for a beneficiary during the performance period by calculating the risk-adjusted per capita cost for beneficiaries attributed to an individual clinician or group of clinicians. The new aspects of the cost category for 2019 aspects of the cost category for 2019 is that there are 8 new episode-based cost measures. And those are all listed here on this slide, and most of them are procedural, and there are a few acute inpatient medical conditions. So definitely go onto the Quality Payment Program website to review each of these individual measures to learn a little bit more about them. So improvement activities. So within improvement activities, you can earn up to 15 MIPS percentage points. The performance period is 90 days up to a full year, and there are 118 MIPS improvement activities to choose from. The reporting does continue by yes/no attestation, so if you did report for 2018 MIPS, you'll know that you went into the improvement activities category. You could search for the improvement activities you completed in 2018, and then you would just click on that to say that you completed it. Promoting interoperability bonus points have been removed for 2019. There are 6 new improvement activities for 2019. They're listed here on this slide. If you were looking for something new last year and wanted to find something, these would be a great place to start as they're brand new. One thing I do want to mention, for many improvement activities, they can be completed year after year. There are a few exceptions to that, and you can see those on that Quality Payment Program website. A lot of times, some of the classes only allow you to complete them once every 2 years or once every 4 years, but the vast majority of the improvement activities allow you to continuously complete them. So you could do the same ones from 2018 and 2019. There are 5 modified activities, and those are listed here as well. So if you completed any of these in 2018, I highly suggest that you go in and look at these again, see what the changes were, and make sure that you're still meeting the requirements for these improvement activities. And then finally, one improvement activity was removed. So it was called Participation in Population Health Research, IA_PM_9. And the reason it was removed was because CMS felt that it was very similar to another improvement activity that actually had the same exact name, Participation in Population Health Research, IAPM_17. So if in previous years you attested yes to IA_PM_9, we highly suggest that you go in and look at IM_PM_17 to make sure that you're still meeting those requirements so you can still attest yes to that. There is some special scoring for 2019 improvement activities. So a clinician can earn full credit or all 40 points within the improvement activities category if the clinician is in a patient-centered medical home. Activities are worth double the points for clinicians in small, underserved, or rural settings and non-patient-facing clinicians/groups. So this just makes it easier for those clinicians to reach the full 40 points of the category. And the way that happens is that within improvement activities, there are medium-weighted activities and there are high-weighted activities. The medium-weighted activities for a clinician in a large practice are worth 10 points. And the high-weighted activities for a clinician in a large practice are worth 20 points. So in order for those clinician types to reach that 40 points within the category, they have to do 2 high-weighted activities, 1 high-weighted activity, and 2 medium-weighted activities, or 4 medium-weighted activities to reach that 40 points. For these clinician types, the small, underserved, or rural settings and non-patient-facing clinicians/groups, their medium-weighted activities are worth 20 points and their high-weighted activities are worth 40 points. So they have to do 1 high-weighted activity or 2 medium-weighted activities. So it just makes it a little bit easier on those clinician types. Now we're going to get into promoting interoperability. You can earn up to 25 MIPS percentage points within this category. The performance period is 90 consecutive days up to a full year, and the maximum category score is 100 points. As I mentioned in the improvement activities category, the bonus from improvement activities has been eliminated. And promoting interoperability has been redesigned for 2019 to prioritize interoperability. So one of the largest changes within the promoting interoperability category is that it requires the use of 2015 Certs to receive any points within the category. The certification is not required until the last day of the performance period selected. So I'm going to give the example of the very last 90 consecutive day period of the year, which goes from October 3rd through December 31st. So this clinician needs to start using 2015 edition electronic health record technology. Their vendor has put it out, but it is not certified. By the end of the year, by December 31st, that vendor needs to have that EHR certified in order for a clinician to receive any points within this category. So you just need to start using it at the beginning of the performance period, and it needs to be certified by the end of the performance period. So that's how that works. And if you're not sure if you are 2015 cert, we recommend talking with your vendor, finding out, making sure that that's something that's on the forefront of what they're doing to make sure that that's complete by the end of this year. There are some exclusions within the promoting interoperability category. A lot of these exclusions are those newly eligible clinician types, and this allows those clinician types to have their promoting interoperability score reweighted automatically and shifted to the quality category. So these are hospital-based clinicians, physician assistants, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetist, non-patient-facing clinicians, ambulatory surgical center-based MIPS eligible clinicians, occupational therapists, clinical psychologists, speech-language pathologists, registered dietitians or nutritional professionals, and physical therapists. So the scoring for promoting interoperability, other than having to have 2015 cert, to earn a score greater than 0 for promoting interoperability category, participants must attest yes to 3 questions. The prevention of information blocking, which just means that you didn't turn off any functionality within your EHR that blocked information. The Office of the National Coordinator for Health Information Technology's direct review, which has more to do with your EHR, and it would be something you would know if you needed to attest for, and then complete a security risk analysis during the calendar year in which the MIPS performance period occurs and have proof. So that's that SRA, and you want to have proof just in case of an audit so that you can easily send that off. And then the second part is that you report the required measures from each of the 4 objectives. The 4 objectives are EPrescribing, provider-to-patient exchange, health information exchange, and public health and clinical data exchange. So within EPrescribing, there are some bonus or optional opioid measures, and I'll highlight those in a few minutes. So EPrescribing is the transmission of at least 1 e-prescription through Certs. Provider-to-patient exchange is that the patient is provided timely access to view, download, and transmit his or her information. And then health information exchange. So the first is support electronic referral loops by receiving and incorporating health information. So for at least 1 electronic summary of care record received, the clinician conducts a clinical information reconciliation. And then support electronic referral loops by sending health information. For at least 1 transition of care or referral, a summary of care is created using Cert and is then electronically exchanged. The public health and clinical data exchange measures, you must be in active engagement with 2 of the following: immunization registry reporting, public health registry reporting, syndromic surveillance reporting, clinical data registry reporting, or electronic case reporting. So active engagement with 2 means that it could be 2 public health registries. It doesn't have to be 1 immunization and 1 public health registry. So in the state of Michigan, the immunization registry reporting that's available is the Michigan Care Improvement Registry, or MICR. The public health registry reporting options are the Michigan Cancer Surveillance System and the Michigan Automated Prescription System. For syndromic surveillance, unfortunately, we do have the Michigan Syndromic Surveillance System, but unfortunately, they no longer accept data from clinicians in non-urgent care settings. Then we have the clinical data registry reporting, which includes some QCDR. So if you are using a QCDR, you can check with your vendor to see if they have the option to do some clinical data registry reporting. And then electronic case reporting, you have the Michigan Disease Surveillance System. If you want to get some more details on any of these, if you're in the state of Michigan, you can look at Michigan Health IT. The Promoting Interoperability category, clinicians are required to report on measures from each of the 4 objectives unless an exclusion is available. And we added 2 new optional / bonus measures from the EPrescribing objective. The first is Query of Prescription Drug Monitoring Program, which in the state of Michigan is MAPS, and then Verify Opioid Treatment Agreement. So if you do each one of those, they're each worth 5 points, so you could get a total of 10 bonus points. Some other ways to get some bonus points include the complex patient bonus. So you can receive up to 5 bonus MIPS points proportional to the level of clinical complexity and risk of a clinician's patient population. And it's granted only if data is submitted for one of the following categories: quality improvement activities or promoting interoperability, which are the 3 categories that you would report on. So what are the important dates for the 2019 performance period? So first is that on January 2nd, 2020, the 2019 MIPS performance period reporting window opens. So that's the first day that you'll be able to log into the QPP website and start inputting your data. On March 31st, 2020, the MIPS performance period reporting window closes. You don't have a submit button. Once you enter in all of your data, it's saved in there. You'll be able to exit and re-enter the system anytime between January 2nd and March 31st to look at it and edit anything you might need to edit. But on March 31st, 2020, it will close down and all of that information is sent on CMS. On July 1st, 2020, the 2019 MIPS performance data should be available on the QPP portal, which means you'll be able to log back in and look at that. And then finally, on January 1st, 2021, the performance year 2019 payment adjustments go into effect. So that's all I had on the MIPS side of things. Now I'm going to get into the 2019 advanced APM category changes. So what are advanced alternative payment models? So first I'm going to talk about what are alternative payment models. So these are new models of paying for healthcare that incentivize quality and value over volume by moving away from traditional Medicare Part B physician fee service. Advanced APMs are a subset of alternative payment models that receive a 5% bonus payment if eligible clinicians meet thresholds to become qualified professionals, or QPs. So there are some APM snapshot dates, kind of similar to the MIPS determination period. So CMS will apply the APM scoring standard using each MIPS APM entity's participation list at 3 snapshot dates. So March 31st, June 30th, and August 31st. If you participate in a MIPS APM but aren't on the APM participation list on one of the 3 snapshot dates, you won't be scored using the APM scoring standard and should instead report to MIPS as an individual or group. So you always want to be checking that participation lookup tool to make sure it's listing the correct information for your clinician. If an eligible clinician joined a Medicare Shared Savings Program after August 31st, a 4th snapshot, December 31st, will be used to determine APM participation. This 4th snapshot is not part of the qualifying APM participant snapshot dates. So what are those MIPS APMs? So MIPS APMs are kind of the middle ground between reporting to MIPS categories and being a full-fledged advanced APM. So you can kind of see it there up above, how it's kind of right in the middle. And an example of a MIPS APM is a Medicare Shared Savings Program, MSSP, Track 1 Accountable Care Organization. And these clinicians oftentimes only have to report promoting interoperability. So the scoring for MIPS APMs is slightly different as well. So the scoring goes as follows. The quality category is worth 50% of their score. The improvement activities category is worth 30%. Promoting interoperability is worth 20%. And cost is worth 0% because it's not measured on cost because they are already being assessed on cost and utilization via the requirements for participation in the MIPS APM. And as I mentioned a little bit earlier, Track 1 MSSP ACOs are APMs and they're MIPS APMs, and they're likely to only have to report for that promoting interoperability category. Typically, ACOs report on the other categories on behalf of the ACO participants. We always suggest checking with your ACO to see what they require you to report. So for those MSSP ACO participants that are Track 1+, 2, and 3, or next generation ACOs, and those that are listed as qualified participants on the participation lookup tool that I mentioned earlier, they have no need to report for MIPS because of the requirements to become a QP or qualified participant. And they earn a positive 5% payment adjustment. So this is what it would look like if you are a qualified participant. It would show that you are not MIPS eligible, and the reporting requirements would list this clinician is not required to report because they are a qualifying APM participant. So for qualified participants, they must receive at least 50% of their Medicare Part B payments or see at least 35% of Medicare patients through an advanced APM at one of the snapshots that I mentioned earlier. And 75% of practices need to be using certified electronic health record technology within the APM entity. And there's no reporting required due to the requirements to become a QP. Another category that exists are partial QPs. So partial QPs must receive at least 40% of Medicare Part B payments or see at least 25% of Medicare patients through an advanced APM entity at one of the snapshots. And they may choose whether or not they want to participate in MIPS. If they choose to participate in MIPS, they must meet all MIPS reporting and scoring requirements. If they choose not to participate, they will not be required to report to MIPS and will not receive a MIPS payment adjustment. So that's what I have for you today. I want to mention the QPP Help Desk, and their hours of operations are Monday through Friday, 8 a.m. to 8 p.m. Eastern Time. You can see their phone number and their email address listed there. And then they have the awesome resource of the QPP website, which is qpp.cms.gov. You can sign up for their listserv. You can check out their resource library. They really do have a ton of information that could probably answer a lot of your questions right on the website. The resources that are available at this point in time are the QPP Technical Assistance for practices of greater than 15, which is the Lake Superior Quality Innovation Network. One thing I do want to mention about that is that a few weeks ago, CMS sent an email, and we want to make sure you're aware of those upcoming changes to the Quality Payment Program technical assistance support Lake Superior Quality Innovation Network provides to larger physician practices, health systems, and accountable care organizations. The change in support, as I mentioned, was included in a recent announcement from the Centers for Medicare and Medicaid Services. So after July 17, 2019, the National QPP Service Center serves as a primary point of contact to help address your questions and concerns. Please connect with the QPP Service Center at 1-866-288-8292 or via email at qpp@cms.hhs.gov. So after July 17th, Lake Superior Quality Innovation Network is no longer the contact for practices of 15 or more clinicians, of clinicians in practices with more than 15 clinicians. There is still QPP Certs Assistance, and that is technical assistance for small practices, 15 and under, and that's through the QPP Resource Center, which you can find right there. And then finally, there is the Stratus Health MIPS Estimator, which allows you to enter some scores in and see what a potential MIPS final score would be. Now I just want to go over a couple other things. For 2019 to 2024, CMS has outlined these 5 broad priorities for the Quality Innovation Network Quality Improvement Organization Program. So those are improving behavioral health outcomes, focusing on decrease in opioid misuse, increasing patient safety, increasing chronic disease self-management, increasing quality of care transitions, and improving long-term care quality. Lake Superior Quinn Partners, MPRO, Medistar, and Stratus Health would like to thank you for all of your hard work to advance the health and healthcare of your patients with us for the past 5 years. As we look to the future of improving quality on behalf of Medicare beneficiaries, our 3 organizations have entered into a new partnership called Superior Health Quality Alliance, or Superior Health, which is strengthened by the addition of the Illinois Health and Hospital Association, Michigan Health and Hospital Association, Midwest Kidney Network, Minnesota Hospital Association, and Wisconsin Hospital Association. We each have success driving achievement of Medicare Quality Improvement Program goals as either a quality improvement organization, Hospital Improvement Innovation Network, or End-Stage Renal Disease Network. Superior Health members currently improve healthcare in Illinois, Michigan, Minnesota, North Dakota, South Dakota, and Wisconsin, and have experience improving healthcare inequality nationwide. As Superior Health, we aim to support the Centers for Medicare and Medicaid Services in improving the quality of health and healthcare delivery for healthcare consumers, providers, and communities in our region and across the United States. So I just want to thank everyone for tuning into this video today. If you do have any questions, my name is Alina Smith, and you can find my contact information there. Again, any questions from larger practices of 16 or more clinicians after July 17th should be directed to the QPP Service Center. Thank you for joining me today.